Professor Dr. Clemens Heiser is the head of the sleep department at the hospital Rechts der Isar in Munich, Germany. He's trained in sleep medicine and head and neck surgery. His specialty is the diagnosis and treatment options for obstructive sleep apnea. Currently, his main research focus is hypoglossal nerve stimulation and pathophysiology of respiratory sleep disorders, and he is a key opinion leader in this field. He is also a co-author of more than 220 peer-reviewed publications and was awarded the prestigious Anton von Troeltsch Award from the German ENT Society for his work on the anatomical variations of the human hypoglossal nerve. Professor Heiser is the co-founder of the Institute for Sleep Medicine Germany, which engages in educational programs for physicians and other stakeholders. Please, Professor Heiser.
Thanks so much for your invitation today and giving me the chance also to participate in this very nice webinar about obstructive sleep apnea and tongue-based problems. So I was kindly asked to talk today about non-ablative surgical procedures. First of all, I would like to give you my conflict of interest. I'm also talking a little bit about hypoglossal nerve stimulation today, and I received research grant and consultants from Inspire Medical Systems and Nyxoah. Both companies are involved in hypoglossal nerve stimulation. So what do we know, or to give you a short introduction? Everybody knows that the airway is obstructed, right? And I know that I think all of you are familiar with it because you're ENT sleep physicians. If you're doing a DISE, a drug-induced sleep endoscopy, on the left side, you really see how the tongue base is obstructing the upper airway. On the right side, it's more the soft palate. And we really know that we need to find a surgical way to open up this upper airway. So I would like to get you on my journey and probably some new thoughts how we could consider these problems. We have heard from from further talks in this webinar from Rodolfo and Filippo how probably which opportunities are available if we are talking about any tongue-based resection in an ablative way, coblation, robotic, different resection techniques available. I don't want to go in detail. But of course, if you talk about non-ablative techniques, it's a kind of a tongue-based relocation, right? And there we can find on the one hand the radiofrequency therapy. To be honest, it's not a really relocation of the tongue base, it's more stiffening, but I would also consider it in this part. Also, we can talk about tongue suspension. There you can take different sutures, for instance, or the genioglossus genoplasty advancement. I put in brackets the hyoid suspension. It's more on the hypopharyngeal level. Of course, it also has effects or huge effects on the tongue base. But to talk also about hyoid suspension, this would take right now too much time. And this is what my research focus was in the last few years, and also where I looked for my patient. It is more the electrical stimulation, the hypoglossal nerve stimulation. In the beginning, it was really the tongue-based stimulation as a non-ablative procedure. But I will show you at the end of my talk, there is a lot of new things coming up in the next few years about the Ansa cervicalis stimulation, the internal superior laryngeal nerve, the tympanic trunk, and probably a combination of all these therapies that we are able to open up our upper airway. First of all, I would like to talk a little bit more about the tongue-based relocation and therefore the radiofrequency. This is already a pretty old publication from Stuck, a German ENT and sleep physician from Mannheim, now in Marburg. He's the head in Marburg, who investigated what are we really doing if we apply to the tongue-based radiofrequency. And there are different techniques now available where probably to put the needles into the tongue and what has probably the best outcomes. During these times, in the beginning of the 2000s, just 2 points, they were just applying the needles into 2 different incision sites, but they did an MRI study on it. And what I really find it interesting, because in the beginning we thought that we probably will really reduce the tissue volume, they figured out that we are more doing a scarf into the muscle, in the lymphatic tissue, and it is more stiffening of the tongue base and not really a shrinking of the tongue base, what we probably would thought, or as we probably would know from the nasal, the inferior nasal turbinates. That was the latest publication I found, or review on radiofrequency application for obstructive sleep apnea 5 years ago. And here you can see they were looking at the tongue base, and they figured out that in all publications, significant reduction of the AHI, RDI, on the one hand, on the lowest oxygen saturation, ESS and snoring could be. But again, but the problem which a lot of surgical techniques on obstructive sleep apnea from scientific point of view is 3, 4, 5, 6 months. And no data is available in the later on less than 15.5, for instance, which would probably convince a conservative sleep physician about these surgical techniques. Also from Wehr et al. Published 1 year earlier in 2014, a review on radiofrequency of the tongue base. They found out that this was very effective in snoring. And we know also from our clinical practice that it has a very low morbidity, but again, just data available for 1 year. And there was some data also available suggesting that there will be probably an improvement up to 5 years, but this is not on a very high evidence level. So if you talk about a little about tongue-based relocation, you also, of course, need to talk about the tongue suspension techniques. And I think most of you are familiar with it, or the most probably used system worldwide is the repose system, now from Medtronic. And the technique is that you put a suture in the inside of the mandibular, and then you take a suture through the tongue base in a different way, suturing the tongue base, and then you can screw it, and then you can move the tongue base more anteriorly. What are the results about it? So I found a review article just 2 years published of these tongue suspension techniques. But the problem is a little bit, to be honest, and this is why I highlighted red, it was in combination with UP3. So it was always a multi-level surgery they did. In this clinical trial, sorry, it was not review, a clinical trial. And if you look at the total AHI, to be honest, it was not really convincing. But then the author starts to define 2 different groups, one success group, one failure group. And if you look at the success group, you really could see almost a 70 up to 80% AHI reduction, which is really convincing. But I think this is a problem of all surgical, or a lot of surgical techniques, also of neurostimulation, that we are not having a real good tool right now available to define before we do surgery if the patient will be probably successful or if the patient will probably a non-responder, a failure. There is also a nice review available. It is a little bit older, 6 years ago, from the group mainly from Netherlands and Belgium, who analyzed this. And they found out that if you just do a suture tongue suspension, that the surgical success rate is round about 40%. But again, as I told you, for the radiofrequency technique, the follow-ups are pretty short, to be honest. If you consider that probably most of the patients are 40 or 50 and have a life expectancy of 30 or 40 more years. If you combine this tongue suspension technique again with UP3, you can see that you have an increase in the clinical outcome, a 60% AHI reduction on average. But that does not mean that just 40% or 60%, this is something, I mean, every second patient is getting a responder and every second patient is getting a non-responder. That does not mean that there are no scientific research groups right now more available in this world. There is a really nice there's a really nice work available, scientific work from Biak, who is now working, or an ENT physician from Marburg, who measured the isometric tongue forces between healthy individuals on the one hand and patients with obstructive sleep apnea on the other hand. And what they figured out, that there was no difference between both patients. And one important point was also they figured out how much power the tongue is developing when the muscles are contracting. And this is also important for the next work. On the next slide, I will show you, because they figured out that the medium or the average of tongue force is round about 10 Newton. And this is just EPUB ahead of print, just published last year. A group, they were using an animal pig, and they were using a new needle and a new material for the suture technique, polydiaxonone and polyurethane combination. And they figured it out that this will be able to be effective against the power of 60 Newton. And if you compare it to the work before, so probably, because this was, I mean, probably a few of you still know the Phillips anchors where breaking was a huge problem, or anything else, they figured out that this still would work till 60 Newton. So there is still research going on in the world outside, animal research, basic research, to find new techniques, or at least new materials to do probably, or to perform the tongue suspension technique. So I think we need to follow up this in the next few years. Then there is also the genioglossus, genioplasty advancement. And I really like this figure because it is an MRI and it shows you the opening of the upper airway if you modify the skeletal morphology. So this is before surgery, this is after surgery. You see, it was not just a genioglossus advancement. They combined it with an MMA, a maxillomandibular advancements. But if you look at this wide zone over here before surgery, after surgery, you can really see how the airway opens, how the airway increases. And I find this pretty impressive. And this is also something which shows that in the future, we really need not probably just to think of one technique or just of one anatomical finding, that we really need to consider more things. And what they found out in this group 2 years ago is that the genio muscle and the power of the genio muscle is influenced by the vertical mandibular position, but also by its anterior placement. And to increase the activity of the genioglossus muscle in patient with a small jaw opening, the jaw should be protruded. And this is a very, very important information probably for us as surgeon, that if we think on the one hand on a conservative treatment on an oral device, that also probably the jaw opening is important, but also on the other hand, if we consider patients probably for genioplasty or probably for a genioplasty advancement or for even hypoglossal nerve stimulation, where we are stimulating the genioglossus muscle, that also the jaw opening can play an important role. And here, because I like the interoperative figures in this publication, where you can really see how the genioglossus advancement is performed, and that you try to do nothing else than an anterior placement of the anchoring of the genioglossus to open up the upper airway in an anteriorly direction. But also, and this is, I know the guys who know me very well, I love to talk about neurostimulation of the upper airway, the tongue-based, as a non-ablative technique. I would like to get your thoughts of it and probably ideas on a wider, more open way. We know that the anatomy of the upper airway is very complex, right? And it's not yet completely fully understood. We know that more than 22 muscles are involved. We consider the genioglossus muscle as the main airway opener because of a very tremendous work during the 90s and 2000s of the group around Andrew Wollman or Danny Eckert, who were considering all this from the USA and from Harvard. But I will let you know that the genioglossus is probably important, but he's not the only muscle which we probably need to target. And if you think about it, on the one hand, there's a surgeon, right? And on the other hand, there is a conservative sleep physician, a pulmonologist. And there are two worlds coming together. Because I think that in the last few years, or in the last decades of years, when we were talking about obstructive sleep apnea, surgeons always thought about it in a mechanical way. If you talk to conservative sleep physicians, mainly pulmonologists, but also cardiologists, neurologists, they would think probably more in a chemical way. They try to figure it out to find any drug or medication to open up the upper airway. That was the best thing. But CPAP is also working for that. But I think both groups, or all of us, especially all of us as surgeons, we need to think outside of the box. Because we know today that and this I will show you in the next slide, the mechanical airway thinking we had probably, especially on the tongue base, is much more complicated. But this is also the same for the chemical way. And if you now try to get this figure on obstructive sleep apnea patients, of course, we know the anatomy is very complex, it's very difficult, and it's not as easy as we thought in the beginning when we started to develop different techniques. But also, on the other hand, sleep physicians understand there is much more things probably which we need to consider in the future if we treat patients with surgery for their sleep apnea. And that's loop gain, that's arousal threshold, that's the neural control. Until today, we do not know if this is really the answer for doing a phenotyping or endotyping of our patients. So again, neurostimulation. Right now, what is available? What can we do? We know that there are 3 companies right now available. LivaNova will come with a new device, probably the second or third quarter of this year, the old Inferior device. They are stimulating the main trunk of the hypoglossal nerve to stabilize the tongue base, to stabilize the upper airway. Then there is the already old traditional system, unilateral breathing synchronized system, the Inspire system, a selective stimulation for active opening on the upper airway. And there is also now, since last year, at least over here in Europe, available, not yet an FDA approval, but I think it will come probably soon this year, for bilateral stimulation of the hypoglossal nerve, the Nyxoah, the Genio system, which is also an active opening, putting the genioglossus muscle forward to open up the upper airway. So going back to these 22 muscles, which I have shown you, who help us to open up the upper airway, every surgical technique of the tongue base I was presenting, the old one, the traditional one, the genioplasty, the genioglossus advancement, radiofrequency of the tongue base, or whatever, always thinks of an anterior direction to open up the upper airway. And that's the same also with hypoglossal nerve stimulation. But I can let you know that's not the end of the story. I mean, still we do not know why during wakefulness, patients who fall asleep really got a severe sleep apnea, right? And I can tell you, if we are doing a tracheal traction, that means a caudal traction of the upper airway, by probably stimulating the sternothyroid muscle groups, the prelaryngeal muscle groups, we are also able to stabilize especially the lateral walls of the lateral pharyngeal walls. And also probably, if we talk about the constrictor muscles, if we are getting an increased pharyngeal muscle tone in these muscles, we will have a posterior opening up of the upper airway and also stabilizing it. And all this work, which I'm going to present you here in the schematic drawing and also in the new figures, have been developed by David Gant, a good friend of mine from Vanderbilt, and also Alan Schwartz from Baltimore. So, and this is the publication which is just available from David Gant, and it's so impressive if you look at the pictures. What they did, they stimulate with a transcutaneous needle the hypoglossal nerve, but they also tried to do this caudal traction, and they stimulate the Ansa cervicalis, the lower part of the Ansa cervicalis, that you are able to open up, or that you get muscle contractions of the sternothyroid, the larynx and the hyoid is moving downwards, and you are stabilizing the lateral walls, the lateral pharyngeal walls, and you have greater effects of the upper airway if you combine hypoglossal nerve stimulation and Ansa cervicalis stimulation. And if you have a look, a more detailed look on this publication, the result seems to be very, very promising. So Ansa cervicalis stimulation probably will definitely help us in the next few years. There are right now more research projects going on, and Vanderbilt David Gant decided to work together with the company Nyxoah over here in Europe, probably to develop a new product. But this is not all. There is also Met-El, the company working together also with a good friend of mine, with Joachim Maurer von Mannheim. I think a lot of you are also familiar with him, on the inferior superior laryngeal nerve stimulation. In the beginning, when you think about it, you think, what has this superior laryngeal nerve, who's responsible probably just for the sensitivity of the larynx, how can we, if we are stimulating this nerve, how we can treat obstructive sleep apnea, right? But they figure it out in animal models and also in a few humans, that the stimulation of this nerve is able to elicit a specific genioglossus response. And also what they could show is that they were able really to stabilize the upper airway. So the first animal results on the one hand, and also the first in-human trials with transcutaneous stimulation probes, seems to be very promising. And again, that's not all the story probably, how we could be able to stimulate the upper airway and to get really great effects of it. There's also, I'm showing you the patent of Galvani. Galvani is a company from England, Great Britain, in London. 50% is Google, 50% is GSK, GlaxoSmithKline, and they decided to stimulate the superior cervical ganglion. And they did animal studies, which are very, very promising. What they could show in this animal study, because everybody is probably afraid in the beginning to have any effects on the heart, for instance, on blood pressure, but they had positive effects on it. They could show nothing happened in the ECG, but they showed that we have a decrease in blood pressure, and they could show, and this could be very promising, if you are talking about obstructive sleep apnea, they could show that have a decrease in pressure in the upper airway, and they could open the upper airway in the animals at least. So also this could be a combination if you have patients with central sleep apnea and obstructive sleep apnea, to stimulate probably the superior cervical ganglion. And if you now go a little back in timeline, the first genioglossus advancement in obstructive sleep apnea has been published in 1993. The first hypoglossal nerve stimulation was Paul van der Heining with the Inspire 1 system in 1996 in Antwerp. The first radiofrequency therapy was in 1999. The first tongue suspicion in 2000. The bilateral stimulation of the hypoglossal nerve, at least CE market, in 2020, and the publication. David Gant with the Ansa cervicalis stimulation last year, this year, doesn't matter. But if you just think about it, we are going to have probably a new way in a surgical thinking. We need to consider in the future how we are going to treat our patient. And it's not just a neurostimulation, I will let you know. We will talk about probably more of a neuromodulation of the upper airway. Combination of different nerves, different tools are available, probably combined also with traditional surgery, that we have much greater effects on the upper airway than we had in the last, probably in our last clinical trials on everything you have seen. We will talk a little bit more about this when we founded the first European Sleep Surgery Academy meeting. We will talk about good old traditional things, but we will also talk about neurostimulation. It will be Professor van der Wegen, who is the head of this, who is going to have the first meeting in June this year. So everybody who is interested can register if he wants. And also I would like kindly to ask everybody of you to become part of the European Academy of Sleep Medicine. It's a free membership. We are a subgroup of the European ENT Academy. You don't have to pay any fee, any amount. Please join us, because I think that we as sleep surgeons need to be connected together and to develop as ENTs the field of obstructive sleep apnea. Thanks so much.
Thank you, Professor Heiser, for this great lecture, really interesting. As you have mentioned, probably for, let's say, collapsible tongue, which is obviously the problem which can be solved by non-ablative procedure. What, in your opinion, since upper airway stimulation, whether we are talking about hypoglossal or Ansa cervicalis, or even stimulation of sensorial nerves, this kind of therapy is not accessible in all countries, since it's not reimbursed yet. What do you think? What are the other options that could be usable for these patients when we are talking about the tongue-based collapse?
Yeah, I totally agree. I think you need to probably to separate this a little bit more. If you go for probably really not really severe sleep apnea, if a patient is just snoring or something like that, I think radiofrequency is probably right now the best thing if you really want to treat the tongue base. I did a lot of research also on snoring sound analysis with artificial intelligence, and we also looked at 15,000 dices from a friend of mine and analyzed together with the snoring sounds, and we figured out that 80 or 90% of snoring is because of the soft palate. And this makes probably also the most sense. But if you really think that your patient is also just snoring or has light sleep apnea, probably you should consider radiofrequency, because the morbidity is very, very low. If it comes to moderate or severe sleep apnea, I think that a tongue-based treatment alone shouldn't be probably the right treatment. It is always a combination normally in most of the patients between tongue-based surgery and soft palate surgery. And then it really depends on the surgeon, right? If he is well trained in doing a genioplasty, for instance, if he is trained in doing one of these advancements, or also if he is probably trained in doing an ablative, like a chelation technique or something like that. But I think these classical ablative techniques, like a genio, like you have seen in you really can increase the reduction in the AHI if you combine it also with soft palate surgery. I totally agree with you that the neuromodulation is a very expensive treatment right now. But I will also let you know, as you see more and more companies coming up, it will be definitely getting much cheaper. And then it will be probably also available in countries who are not as rich as Germany is. I completely understand this, and I see also this problem. And probably there will be one day where we will just do a transcutaneous stimulation, and then surgeons are not needed anymore. But this will be a very sad day, to be honest.
A sad day for us and a happy day for the patients, which is what is really important. You have any other experience with non-surgical therapy, like mandibular advancement devices, myofacial, myofunctional exercises, and things like that? You ever use it?
Yeah. I have also my own sleep lab, so I'm offering also my patients oral devices a lot. Yeah, because especially for mild sleep apnea, oral devices can, in younger patients who are not too much overrated, it works perfectly, and a lot of them wants to use it. I'm working here with a dentist together who is also trained in sleep by the German Sleep Dentist Society, and this works perfectly. So oral devices are used here in my sleep department every day. I don't have so many myofunctional therapy. I don't have so many experience with it. I have 2 or 3 patients who were just snoring, and I sent to a trainer, and he did it. It got a little bit better, but this is something which I cannot judge on it, to be honest. But oral devices are perfect.
Can you tell us which criteria would you use to detect the treatment success? So besides AHI, which criteria do you use usually to say, okay, this therapy works for this patient?
I mean, the AHI we have talked about so many times. It's useless, right? We should stop commenting on this. For me, more important is the ODI, or the time below 90% of oxygen, because this probably definitely correlates better regarding the cardiovascular outcome. But I think it's really hard for us because we also need to consider how the patient feels, right? And this will be something which will get more and more important in the next few years, at least if it comes also to reimbursement over here it has come over here in Germany. So also that the patient feels an improvement in probably snoring, in his sleep quality, in his sleepiness during the day, that he is probably feels improvement during his work or whatever. This also will be very important. So I also try for my patients to consider everything. On the one hand, if there is an improvement in patient, and on the other hand, if I look at the PSG or home sleep test data, it is more the ODI or the oxygen desaturation below 90. If the oxygen stays more or less the whole night over 90%, I don't care about the AHI. If the AHI is still 20, who cares about it? The oxygen is stable.
Thank you.
So this is an endless debate about outcome measures, which I think we should renew it from time to time, because, like you said, not only AHI, ODI, and below saturation below 90, but even if you take a look at the respiratory polygraphy, like examination, it's not all. So how patient feels is probably more important.
And that's also a very important point you're mentioning. What we need is, we need to record our patients also on a long term. Yes. We have an artificial environment if he comes to the sleep lab. Of course, it's a little bit better if we are doing a home sleep test. But what we need is a non-touchable device next to the bed of the patient, recording for 4 weeks, 8 weeks, 12 weeks. Nobody knows what happens from night to night or over a long term.
That's very important, and what you said, the biggest thing, we have different measuring tools that are not so invasive right now, but the thing is how to make it multi-night measuring, and I'm really optimistic looking at wearables, new wearables that are developing very fast, and I think this will bring big breakthrough in OSA diagnostic, because it's the long run we have to measure, not 1, 2, or 3 nights. Also in this way you can try different therapies, not just one, but you can try one therapy, positional, one surgery second, and so on. So
definitely.
Let's hope this will change. Yes. Okay, big thanks to our speakers, attendees, and sponsors, our media production team, and Composter Design for your help and support. I hope everyone got some new practical knowledge to use in clinical practice, and maybe also some inspiration for future work in this field. You are all invited to visit OSA Academy webpage and use it in the best way you can. We will continue with our efforts to bring together some of the best specialists dealing with OSA and share it with you. Anna, thank you for taking the trip and coming here to host this meeting with me.
Dear Matej, the pleasure was all mine. We wish you all good luck, and hopefully we will see you soon alive, in person, of course.
Let's hope so. Stay happy and healthy. Goodbye.
Bye-bye.